So I have been talking about how to be accurate in making a diagnosis. So I want to make a differential diagnosis from periodontal lesions. So primary endodontic lesions with secondary periodontal involvement usually show a single deep probing defect on just one aspect of the root. For example, here you see endo lesion. When the endo lesion develops, you see a deep probing depth, very narrow, deep probing depth, only on one aspect. And there's no plaque or dental calculi on the root. So this is very typical of endodontic lesion. However, primary periodontal lesions show several deep pockets with plaque or calculi on the root. For example, here you see calculi on the root and several deep probing depths around the root. This is very typical of periodontal lesions. But if you have both, like several deep pockets, calculi on the root, and you have endo lesion and perio lesion, what can you do? You have to always start with endo. Then you also have to do perio. So you have to do both, endo first and perio next. Then you will remove periapical lesions. So my friend Rikuchi showed, so, the pulp tissue can be necrotized by way of the infection from the lateral canal or apical bifurcations. So you see you see bacteria can invade compromised blood vessel in the lateral canals and apical ramifications. And the pulp can be necrotized because of that. So sometimes you find the pulp tissues completely necrotic because of the lateral canal and because of the apical ramifications. And we could have furcation canals. It varies. Reports range from 2 to 3% to 76%. A big difference. So almost, if you have doubt, you need to look for the furcation canals. I always, take CBCT and take a close look at the CBCT imaging, and under the microscope, I look for the furcation canals on the palpal floor. And when the root was exposed because of the gingival recession, maybe the pulp can be necrotized because of the bacteria coming into the dentinal tuberous from the exposed root. Because you have lots of dentinal tuberous in the coronal 1/3. If the tooth is vital, you have outward fluid flow in the dentinal tuberous. Whereas when the pulp is necrotic, there is no outward fluid flow from the dentinal tuberous. So the pulp can be necrotized because of that. So if you have cementum barrier, that can prevent bacteria from entering the dentinal tuberous. If there's no cementum, there's no barrier, then bacteria can get into the dentinal tuberous. So like in this situation, A, B, D, it's okay. You have cementum. But if you look at the C, there's no cementum. You see enamel and you see cementum. But between the two, you see the dentin completely exposed. 18% of the teeth have no cementum around CEJ. Okay, so that's why dentinal tuberous are completely exposed to the oral environment. Then, the pulp can be necrotized because of the bacteria ingress into the dentinal tuberous reaching the pulp. So let me show you my case. So this patient was referred to me. The patient was 72-year-old female. And I took a radiograph and CBCT. I found the apical radiolucency together with the perio lesion. I saw 3 deep probing depths, here and here and here. But I ignored the fact that I had 3 deep probing depths. I just did root canal treatment. That's all. I didn't care about perio lesions. And this is immediate post-op. I filled the root canal with MTA. And this is 6 months post-op. Nothing changed. So the next thing I did was I did root end surgery because of the persistent apical periodontitis. And this is what I did. I did root end surgery, and this is what I got. This is immediate post-surgery, and this is 9 months post-op. You see the sinus tract got bigger. Then what I did was I did intentional tooth replantation, but it got worse. And this is what I got after 6 months after the intentional tooth replantation. I didn't do any perio treatment. That's the biggest mistake I ever made. Then the tooth was extracted, unfortunately. So you need to make an accurate diagnosis. If you see both endo and perio lesion, you have to do both, starting with endodontic treatment. So let me go back. You see, this is 6 months after I did root canal treatment. Actually, the lesion size was a little bit smaller. If I had treated the tooth, if I did periodontal treatment on this tooth, maybe the lesion should have been gone. But it didn't. I didn't do that. So this big failure gave me a good lesson. So since I made a big mistake in this case, I always look at the tooth, look at the perio lesions, then I provide both endo and perio treatment. So this is one of the cases where I provided periodontal treatment. So look at, this is a pre-op. You see the big lesion, and you see several deep probing depths. And first I did endo treatment. I waited 1 year, nothing changed. Then instead of just scaling the root, I did intentional tooth replantation because you see very small gap between the buccal root, between the mesio-buccal root and distal buccal root. You see the small space. Look at the small space here. Look at the small space. And I saw calaculi on the root. So that's why I found it impossible to remove calaculi from the small spaces between the two roots. So I did intentional tooth replantation. And what I did was I removed the infection from the space between the two roots, and I pushed MTA into the small space, the defect. Look at the space between the two roots. I actually removed the cementum and dentin, and I put MTA. This is the MTA I placed between the two roots, buccal roots. I waited 6 months showing, look at this, nice periapical healing. So it's very important to provide both endo and perio treatment. Another case, you see a big lesion. Look at this, big lesion. And I actually retreated, and you see the calaculi here. There are several deep probing depths. Then look at the extrusion. This is MTA. I waited 6 months. Most of the MTA completely gone. And what I did was, I did intentional tooth replantation. Look at the calaculi. Look at the plaque. Look at the small gap between the two roots. Then I did the same thing. I removed the calaculi from the two roots, and I put MTA between the two roots. And this is the MTA I placed here, and this is 3 months post-op. You see nice periapical healing as compared to this, like this. Another case, you see, in this case, I only identified a single probing depth, 10 millimeters, on the lingual side. So I actually considered this endo lesions. So I just did endo treatment, nothing else. Then I waited, look at the lesion size, big lesion size. And this is immediate post-op, this is 9 months post-op, and this is the 9 months post-op CBCT. You see nice periapical healing as compared to the lesion here, pre-op lesion. So number 2, so pulpitis, sometimes you find the pulp still vital, surviving the retreatment. So in this case, the patient complained about the pain coming from when the patient drank something hot, not something cold. So every time the patient was male, not female, every time the patient had coffee or miso soup, he had pain. So I took CBCT, I found untreated root canal. So I was very suspicious about this untreated root canal. And when I accessed the mesiobuccal root, I found the pulp still vital. Look at this. So this was responsible for the pain when the patient had something hot. So again, the PDL can be damaged because of periapical periodontitis. So because of the perforation, because of the root fracture, many things could happen. But this is normal. And of course, if you over-instrument the canal beyond the apical foramen, you could damage the PDL. Look at the broken instrument, extruded beyond the apical foramen. Look at the root canal. Look at the root fillings, extruded beyond the apical foramen. So every time the patient bit on something, the patient felt pain. So all you have to do is just remove the cause of the pain. For example, in this case, I removed the broken instrument. In this case, I removed galloperature fillings, extruded into the periapical tissue. Then when you remove the cause, the pain will be gone. This is something you may not know. When you keep placing intracanal medicament, like a calcium hydroxide, you could be the one creating the pain. So in this case, for example, calcium hydroxide is alkaline with higher pH. Formcresol, pH is, formcresol is 12. Calcium hydroxide, 10. Eugenol, actually very low, 4.3. So if you place these intracanal medicaments, you could cause PDLs to be damaged. So this patient came to me, and actually the dentist, the previous dentist, referred the patient to me because he continued placing intracanal medicament, which is calcium hydroxide, for more than 6 months. But the pain didn't disappear. So that's why he decided to send the patient to me. When I saw this, I took a radiograph and CBCT. There's no periapical radiolucency. Why the previous dentist continued placing calcium hydroxide into the root? He said, because every time I did root canal treatment, the patient had post-operative pain. So I continued placing calcium hydroxide. That's what he told me. So you don't need calcium hydroxide because every time you touch the periapical tissues, you are damaging the PDL. So don't do that. So I told him, finish the case, fill the root canal, and don't touch the tooth anymore. Then the pain completely gone the next week. Another case. The patient was referred to me by a general dentist. he actually, again, kept placing calcium hydroxide for more than 6 months. 6 months. And the pain persisted. And I took a radiograph and CBCT. This is radiograph, and this is CBCT. This is calcium hydroxide extruded into the periapical tissue, which caused the pain, post-operative pain. So what I did in this case was, there was no infection, no sign of infection, no periapical radiolucency. So I removed the calcium hydroxide. I intentionally induced bleeding, because bleeding is the first phase of healing. Then after bleeding, I removed the blood, I cleaned the root canal, and I pressed MTA. This time extruded, because MTA is bioactive. And because MTA is bioactive, you can have PDA reformation very quickly. So this is 1 week after I pressed MTA in the canal. And the patient was already asymptomatic. Another case, this is also the same. I have many cases like this. So the patient was referred to me because of the persistent pain. Every time patient bit on something, it hurt. So I took a radiograph and CBCT. There's no periapical radiolucency. So again, what I did was I induced bleeding, I removed calcium hydroxide, and I filled the root canal with MTA. And this is 1 week post-op. The pain is completely gone. The patient was already asymptomatic. And you need to take CBCT every case. You don't want to make any mistake, or you don't want any surprise during the procedure. So that's why I take CBCT every single case. So I took CBCT, you see lateral canal, apical bifurcation, and you see the untreated root canal. This is apical bifurcations, you can see. And this is untreated. So why CBCT? Because CBCT reveals more lesions than PA. CBCT indicates the source of the lesion. It shows the number of the canals and the root curvature, and it shows small anatomical spaces such as an isthmus and a fin, missed canal, and bifurcation, perforation, lateral canal, and root fracture sometimes. But it's not 100%. For example, do you see something wrong with this tooth? This is pre-op radiograph, 2D radiograph. I don't see anything wrong with this, right? Do you agree? Okay, but if you take a CBCT, there's something wrong with this. You see a defect because the cortical plate completely intact. That's why you don't see the lesion in the cancerous bone. When you have intact cortical plate, you don't see nothing in the cancerous bone on the 2D radiograph. So this is why you need to take CBCT to make sure nothing is wrong. If there's no lesion, I will not treat the tooth. But I found the lesion, I retreated this tooth. And you see the external root resorption here. And this study, it's very difficult to pronounce his name, Rodriguez. Am I right? I don't know. He actually found examiners altered their treatment plan after viewing the CBCT scan in almost 50% of the cases. So this is, dangerous. If you don't take CBCT, you can be wrong in 50% of the cases. So you don't want any surprise. And actually, CBCT imaging directly influences endodontic treatment strategy among general dentists and endodontist specialists. So it's very important to take CBCT, so you won't make any mistake. You don't have to change your treatment plan, because treatment plan is very important to be successful. Treatment plan should be made based on CBCT finding, so you can be highly successful in whatever you do. And CBCT data lead to better treatment planning decisions with more predictable outcome. For example, here you see maybe the root end was dissected, but I don't see any periapical radiolucency. But when you take CBCT, you see the root end surgery done, and you see missed lingual root canal. You see the missed lingual root canal? So that's why I was able to locate the lingual root canal, and I was able to fill both the buccal canal and the lingual canal. And this is a broken instrument. You see the broken instrument in a straight root canal. However, if you take a CBCT, you see the broken instrument beyond the curve. This is the distal lingual canal. And you see the lesion associated with the root. But on the 2D radiograph, it's hard to tell. You have the lesion associated with the distal lingual canal. But you can see it on the CBCT image. And you can measure the curvature, you can measure the length of the broken instrument. That's why I was able to remove the broken instrument in 3 minutes. I took it out in 3 minutes. I was very accurate in locating the broken instrument. I was very accurate preparing the canal and took it out in 3 minutes. And this is immediate post-op. Because of my accuracy, I didn't sacrifice lots of denting to remove the broken instrument. And this is immediate post-op. Of course, I obturated the canals with MTA. This is another case. On the 2D radiograph, you don't see nothing wrong. However, if you take CBCT, there's a lesion on the on the lingual side. You see something here. Maybe this is lateral canal. But you don't see anything wrong with the CBCT, with the 2D radiograph, PA. Because you do see something wrong from mesial to distal direction, but you don't see nothing from buccal to lingual direction. That's why you need to take CBCT. This patient said, when I bite, I feel pain from the tooth. So this is the cause of the pain. You see the lesion developing on the lingual side. So here is another case. On the 2D radiograph, you see small PDL widening, and you see the root filling underfilled. And I took radiograph and CBCT. You see the opening of the root canal on the buccal side. You see the curvature, and there's no apical foramen at apex. But you do have the apical foramen on the buccal side. If you don't take CBCT, you may keep looking for the apical foramen at apex, but there's no apical foramen at apex. So this is very important. If you don't take CBCT, you will not reach the apical foramen. Another case, you see no lesion, but you do see Falco lesions. I took CBCT, I found the apical foramen located on the distal side of the medial root. There's no apical foramen at the apex of the medial root. So because of this, I didn't look for the apical foramen at the apex of the medial root. This saved lots of time. So I filled the root canal with MTA. You see a big apical foramen size. So this is immediate post-op. I filled the root canal with MTA. And this is 1 month, 2 months post-op, 3 months post-op, and 10 months post-op, showing nice periapical healing as compared to the pre-op radiolucency, like this. So if you didn't take CBCT, this could never have happened. Another case, you see the big lesion through and through. And there's no, you see the cortical plate on the lingual side completely gone. I did non-surgical retreatment. This is MTA, but nothing happened because of the through and through lesion. What I did was I did surgery, and I did surgery with bone augmentations. But you see something in circle here. You see the circular radiolucency on the PA. What is this? The tooth is not completely healed. What is this? So I took CBCT. I found something here, not from the the root end, but from the concavity on the lingual side. I waited 9 months, then the defect was completely filled with bone. So, but you still see circular lesion under the root. But this is not periapical radiolucency, but this is just from the concavity on the lingual side. So this is not, disease. This is just a concavity. So you don't have to do any surgery anymore. So I consider this healed. Another case, you see small apical lesion, but you see a big lateral lesion. I didn't take CBCT at this time. This was almost 20 years ago. I had CBCT 20 years ago, but I didn't take CBCT every case when I was younger. I just did root canal treatment. I waited 1 year, 2 years. Now the patient developed the sinus tract, and you see the lateral lesion getting bigger and bigger again. So this is kind of emerging apical periodontitis. So I took CBCT. When I had some doubt, I took CBCT. I didn't take CBCT from the beginning, but when I see a failure, I took CBCT. And CBCT showed cemento tear or maybe root fracture that didn't reach the root canal. That's why I didn't see any root fracture inside the root canal. But because of the root fracture, okay, the lesion got bigger and bigger. So I removed the root fracture from here, and this is the fragment of the root here, and I did nothing. I just removed the root fragment. That's all I did. And this is 1 year post-op showing nice periapical healing. I also confirmed healing by taking CBCT. So look at the bone completely reformed in the defect. So when I removed the root, the cementum formed on denting. On the cementum, you have PDL. You see the space, you see the black line on the cementum. So this tooth looks healthy because of healthy PDL. So, and of course, the patient was already asymptomatic, no pain. So this shows how important it is to take CBCT from the beginning. And here you see the lateral canal with a small lateral lesion. Then I knew there was a lateral canal. So I pushed MTA, and I got MTA into the lateral canal. This is 3 months post-op, already showing nice periapical healing compared to this. Of course, the patient was already asymptomatic. So what is the detection rate of the isthmus? So according to this study, the average of, the detection rate of finding the isthmus was 65%. So you don't always find an isthmus on the CBCT imaging. So don't expect yourself to find the isthmus all the time on the CBCT imaging. So sometimes you see an isthmus right here. You can see an isthmus on the actual view, but that's okay. But even if you don't see an isthmus on the CBCT, you could have an isthmus. And do you have to treat the tooth with no periapical radiolucency? It's not necessary. But how do you know that? You need to take CBCT. For example, the patient was symptomatic. Every time the patient bit on something, she had pain. So I took CBCT. I found a lesion on the distal buccal root, but there was no lesion on the distal lingual root. You see lamina dura completely reformed. You see intact lamina dura around the distal lingual root. But you see a lesion associated with the distal buccal root. So because of that, I didn't touch distal lingual root canal. And you see that root canal, I don't see any root canal in the distal lingual root. Maybe calcified. So I don't need to instrument and break into the calcified canal. It's not necessary. There's no benefit of penetrating the calcified canal in the distal lingual canal. So I didn't touch the distal lingual canal. I just retreated distal buccal root. Then the patient immediately became asymptomatic. And this is post-op. Of course, I told the patient, I will not touch the distal lingual canal because there's nothing wrong with distal lingual canal. So what about the detection? What about the root fracture? What about the crown fracture? There's a difference between the crown fracture and root fracture. Crown fracture usually propagate in mesial-distal direction, whereas vertical root fracture propagate in buccal to lingual direction. There's a complete difference between the two fracture pattern. And why you see more root fracture cases in endodontically treated teeth? Because vital tooth possesses protective feedback mechanism to occlusal bite forces. Difference in the maximum bite forces was significantly higher in endodontically treated teeth, which is consistent with the function of dental pulp as a highly sensitive sensor. So if you have vital pulp, you will be more sensitive to biting forces. So it is protected. You don't apply lots of forces. It's not necessary. But when you lose pulp tissues, you lose the sensitivity. That's why you will apply lots of biting forces on endodontically treated teeth. Then you will have vertical root fracture. That's why you see more vertical root fracture cases in endodontically treated teeth. And there are 4 clinical presentations. Presence of sinus tract, increased probing depth, swelling, abscess, and tenderness to percussion when you see a vertical root fracture. So if you see them all, you have higher chance of having a vertical root fracture. So you have to be careful. This is, of course, systematic review and meta-analysis, the highest level of evidence. And if you try to see vertical root fracture with CBCT, there are 5 indications. Loss of bone, mid-root with intact bone, coronal, and apical to the defect. Absence of the entire buccal plate in all spatial views. Radiolucency at the post-root canal junction. Space existing between buccal lingual plate and fracture root. Visualization of the vertical root fracture on the CBCT images. So I always try to see the vertical root fracture, especially on axial view of CBCT. This is very, very easy. Or if you see one of these, you need to be suspicious of vertical root fracture. So I always look at the axial view. No matter which CBCT machine you use, whenever you see the axial slices, you see something. And this is continuous. You see the black line. If you see them on every axial slice, this is very typical of vertical root fracture. So for example, on the 2D radiograph, there's nothing wrong with the root. However, if you look at the axial view, every single axial slice, you see the line, black line, from the buccal to lingual direction. You see the line, and this is another line on a different axial slice. And when I remove the crown, the coronal restoration, I found the same thing. You see the crack from the buccal to lingual direction. You see the crack stained with a caries detector dye. And actually, you see sometimes butterfly effect. So you see, this looks like a butterfly. You see more hardness from medial to distal direction. So mean hardness scores were highest medial distally. So because of more hardness in medial to distal direction, you have vertical root fracture propagating in a lingual to buccal or buccal to lingual direction. So that's why you see the vertical root fracture in the buccal to lingual direction because of the medial to distal hardness here. And also, you can see higher stress concentration in a buccal to lingual direction as compared to the medial to distal lingual direction. There's almost no stress concentration in a medial to distal direction, but you have lots of stress in a buccal to lingual direction. This is why you see so many vertical root fracture from the lingual to buccal direction. So for example, this is a very nice study. If you create a notch on the lingual side and also on the middle side, which crack will develop on the middle side or on the lingual side? What do you think? Lingual, right? Because there's no stress in a medial to distal direction. But you will receive lots of stress in a buccal to lingual direction. That's why this crack will develop to reach the root surface, like this. If you don't do anything about the crack, you will have another crack propagated from the buccal wall reaching the root surface over time. So it's okay to leave the crack on the medial root or distal root, but it's not okay to leave the crack when you see the crack on the lingual side or the buccal side. They will develop, resulting in vertical root fracture. But it takes lots of time, 2 to 3 years on average. Whenever you see the initial crack, don't leave it. Just remove it. And maybe you put composite. If you don't do that, it will take 3 to 4 years before you see the vertical root fracture. So on the 2D radiograph, there is a pattern of vertical root fracture. So if you take a radiograph, PA radiograph from different angles, you see J-shaped radiolucency because of this. For example, you see J-shaped lesion. This is very typical of vertical root fracture. On the CBCT image, you see the vertical root fracture. You can see it. This is obvious. You see the fracture, vertical root fracture. So by the way, you see swelling, sinus tract, and the tooth was sensitive to percussion. Another case, but there's no J-shaped lesion. No J-shaped lesion, sorry. Almost no J-shaped lesion, but you see the PDL widening on the 2D radiograph. But if you take CBCT, you see the vertical crack on every axial slice. Here, you see the crack here, another crack here. So every axial slice, you see the crack. And you see the sinus tract, you see you see the palpation, swelling, and the tooth was sensitive to percussion. So I concluded the tooth was, the tooth had vertical root fracture. So I extracted the tooth, then I found the vertical root fracture here. This is the tooth I extracted from here. In this case, look, I found the vertical root fracture, I found the crack in the medial root and the distal root. However, I didn't see any lateral lesion associated with the root, but I do see apical radiolucency on the sagittal view, big lesion. But I didn't see any lateral lesion associated with the medial root and the distal root. But I extracted the tooth because I saw the cracks in the medial root and the distal root. Look, However, there was no crack on the root surface. Oh my God, I extracted the tooth without a vertical root fracture. Terrible. So I should have trusted the CBCT, what I saw on the CBCT images. So, oh my God, the patient said, can I see my tooth? I want to see my tooth. Can I take it home? No, it's infected. It's heavily infected. So you have seen the cracks. I showed you the cracks here. So you don't have to see it. It's highly contaminated, dangerous. Don't touch it. So again, this is another big mistake I ever had. So every time I made a mistake, I learned something from my mistake. So this mistake tells me, don't extract a tooth unless you see the lesion associated with a crack. I didn't see the lesion associated with a crack. So since this case, I have been very careful. Whenever I see no lesion associated with a crack, even I see the cracks under the microscope inside the root, I decided not to extract the tooth. But of course, I let my patient know you have a crack, but it's not necessary to extract the tooth. So what is the detection rate of the vertical root fracture with the CBCT? CBCT imaging is still not perfect. It's around 83 to 89%. The detection rate of vertical root fracture with CBCT is 83 to 89%. On average, 86. So it's not 100%. Don't trust CBCT in 100% of the cases. But you have to tell your patient, it's not 100%. It's around 80, 85, 86%. So I don't see any cracks on the CBCT. It doesn't mean your tooth is not fractured. And also, you have to maintain pericervical denting in order to prevent vertical root fracture. Because pericervical denting functions as a stress distributor, preserving it may potentially improve the resistance to fracture. So definition of the pericervical denting is the area 4 millimeter coronal to the CEJ and 4 millimeter apical to CEJ. So this area. If you take out lots of denting from the pericervical area, you will reduce the resistance to the vertical root fracture. So if you did that, it's never too late. If you remove pericervical denting, you can just place composite in the defect. Then the tooth will be resistant to vertical root fracture. If you don't do that, the tooth will be susceptible to vertical root fracture. So whenever you see the vertical fracture, what I do is this. It's complicating, so let me simplify the procedure. So whenever you see the vertical root fracture, what I do is remove the vertical fracture, then I place composite in the coronal 1/3, and I reduce the occlusion. And also, not completely. I want to keep it with a light touch. So this is what I do. If you do that, 100% survival rate in the first 2 years, 96% survival rate up to 4 years. So if you do this, you can extend the life of the tooth before you have complete vertical root fracture. So look at this case. I found the cracks both in the mesial root and the distal root. Do you see the cracks here in the back? Okay. I took radiograph and CBCT, but there is no lateral lesion associated with the crack. This is the buccal side, and this is the lingual side. I saw the cracks only on the buccal side, but there's no lesion on the buccal side. So I told the patient, I see cracks in both roots, but I don't see any lateral lesion associated with the cracks. So it's not necessary to extract a tooth. But if you are not careful, if you have the habit, like a parafunctional, biting habit, you could have vertical root fracture in the end. So you have to be careful. Spend more time eating and drinking to reduce the stress. And that's what I told my patient. So first, I filled the canals with MTA. I put composite here and here in the coronal 1/3. And I reduce the occlusion every year. Every year I reduce the occlusion, just a little bit. Then this is 1 year, 2 year, and this is 7-year post-op. The patient stayed asymptomatic. And this is 9-year post-op. The patient was still asymptomatic. No lesion and no symptom. So if you do that, you could extend the life of the tooth by doing that. And of course, you need place composite like this. You need place composite. If you remove lots of pericervical denting, you need to place composite. If you do that, you can make the tooth more resistant to root fracture. So now I want to talk about psychogenic pain. So psychogenic pain is a pain disorder associated with psychological factors. So to make it simple, that is the pain coming from the painful memories. That is psychogenic pain. Psychogenic pain occurs because the pain threshold will be lowered. If the pain threshold goes down, it's easy to remember something bad from your experience. This is called PTSD. And also, pain from temporomandibular disorders may mimic endodontic pain, according to this study. So majority of the patients with tooth pain seeking endodontic treatment had painful TMDs. 1/4 had TMD as a component or sole cause of their pain. So don't just look at the tooth. Look around the face of the patient. Look at the temporomandibular joint. If there's nothing wrong with the TMJ, it's okay. But if you see something wrong with the TMJ, even if the patient is complaining about the tooth pain, you have to tell the patient, the pain is not coming from the tooth, but coming from the TMJ. And, and a memory of experienced pain in the past can make you feel pain from the same area of the injury when you are stressed or depressed. This is called phantom pain. When for example, you lost your leg because of the accident, car accident or something, but you could still feel pain from the same area of the injury. You don't have the leg, but you could feel pain from the area where you had the leg. So this is called phantom pain. You could feel pain from the past memories. So as I told you, this is the escalator, it's not moving. So you are going to step on the escalator that is not moving. It's not moving at all. Look, when you step on the escalator, you feel pushed. When you get out of the escalator, you feel pulled. Because of the experience you had in the past. Experience, the memory of the experience make you do that. Make you feel pushed. When you step on non-moving escalator. But if it's moving, you feel nothing. You step on the moving escalator, you feel nothing. But if it's not moving, you see, you feel pushed. So pain can be felt from the past pain memories triggered by emotion or fatigue. So pain, phantom pain was associated with cognitive or emotional triggers rather than sensory triggers. So it doesn't matter how it feels. What matters is your mood or your emotions. if you feel depressed, if you are stressed, you could remember something that you experienced in the past. You always remember something bad. You never remember something happy when you are stressed, right? When you are stressed, you remember something bad. If you are happy, you don't remember something bad. This is normal. And pain in memory emotionally increases over time. So if you don't do anything, the pain in memory will go up. So don't leave the patient don't keep the patient feeling pain. You have to tell your patient to spend more time eating and drinking and talking. Very important. So this is a very good study. You know, capsaicin. Do you know capsaicin? Capsaicin is the pepper ingredient of the pepper. It's included in the tear gas or something to protect yourself from the bad people. So if you inject capsaicin into the arm, you feel big pain, right? You feel big pain. But if you get anesthesia right after that, the pain is completely gone. But if you inject anesthesia into the arm, then you get capsaicin in the same area, you feel nothing, right? You get capsaicin, you feel pain. And if you get anesthesia after that, the pain will be gone. If you wait 5 hours after you got capsaicin, so what do you think will happen? In group A, you get capsaicin first, then anesthesia. In group 2, you get anesthesia first and capsaicin. Let's wait 5 hours. What will happen to group A and group B? What do you think will happen if you wait 5 hours? Do you think both groups will have pain? The pain returns after the anesthesia is completely gone? What do you think? What do you think? So the group A who experienced the pain will have pain, right? That's what you said? Yes, you are right. Because the first group experienced a big pain because of the capsaicin injection into the arm. Second group didn't experience the pain, right? You don't remember the pain because you didn't experience the pain. The second group never had a pain. 5 hours after the anesthesia is completely gone. So this is very important. The pain memory the pain memory reduces the pain threshold. Okay? So don't let your patient experience the pain. You could be the one to create psychogenic pain. So, for example, if you have preoperative pain and you get treated, you will have more post-operative pain. That's what they found in this study. This is also a nice study, systematic review, and meta-analysis. So the more preoperative pain, the more post-operative pain. There are two ways of having psychogenic pain. First, if you let your patient experience big pain during the endodontic treatment, the patient will end up having psychogenic pain. Or the patient had already experienced pain in the dental treatment. When the patient has trauma, like a psychological trauma, or maybe the patient was depressed, then patient suddenly remember the pain. So this is called top-down from CNS to periphery. And this is called bottom-up from periphery to CNS. So you could be the one to create psychogenic pain. Or you could induce psychogenic pain by providing endodontic treatment because of the mechanism that I showed you. So again, you don't have to see this because I have already showed you this slide. Another case, 6% of endodontic treatment resulted in psychogenic pain. So this study shows the same. 4 to 6% of endodontic treatment resulted in psychogenic pain. So you have to be careful. When the patient is afraid of something, when the patient is concerned about the dental treatment, don't provide the treatment. First, you have to have some consultation. You have to have lots of discussion with your patient. Then, when the patient feels happy, go ahead and do the treatment. But if not, don't do the treatment. You could be the one to create psychogenic pain. And you could have psychogenic pain more in the upper teeth, like these, anterior teeth or posterior teeth, compared to mandibular teeth. I don't know, that's what they found. Why? I don't know. But if you are normal, if you are healthy, everybody has descending pain inhibitory system. What is a descending pain inhibitory system? When you get injured, body reacts immediately to the injury. Then the next thing that body does is the body will release norepinephrine and serotonin. If you have lots of norepinephrine, you feel strong. You don't care about the minor injury. If you have lots of serotonin, you feel relaxed. But if you don't have these, you stay, concerned about it. You stay unhappy about it. So actually, this study showed depression reduces the release of serotonin, which promotes psychogenic pain. So if you are depressed, if you are mentally stressed, you don't have the descending pain inhibitory system. This means you don't have serotonin release. If you don't have serotonin release, you stay worried about the injury that you had. It's very important to understand the pathological processes to healing. 3 main findings emerged. So how do you take care of the psychogenic pain? So as I told you, spend more time eating and drinking. Any food is okay, not any food is okay. So this study showed vegetable consumption contributed the largest share to eating happiness, measured across 8 days. So eat more vegetable. You feel happy. And look at this. This is dinner, tea time, lunch, and breakfast. If you spend more time in dinner time, you will have more happiness. So when your patient is depressed, advise the patient to take more time in dinner time. But sweets on average provided comparable induced eating happiness to healthy food choices such as fruits or vegetables. So when the patient is really depressed, tell them to eat sweets. Then they will be happier. This is how I advise my patient to do. So back to the main subject, serotonin. Serotonin will make you feel happier. So this is the most effective measure to make your patient happy. The more time for eating, drinking, and talking, the more serotonin. Sometimes you can cry. Shedding tears increases the release of serotonin. So you can tell your patient, cry as much as you can. If you are sad, it's okay to cry. Then spend more time eating, especially in dinner time. Take more sweets, vegetables, then you'll be happier. If you don't do that, nothing will be changed. This is what I tell my patient. Unfortunately, the ability of serotonin production for the healthy male is about 50%, 52% higher than that of the female. So men can create more serotonin as compared to female. When tryptophan is insufficient, tryptophan is the product that you need to create serotonin. So tryptophan is insufficient. The serotonin production in brain decreases 4 times more for women than men. This is why you have more female patients with psychogenic pain. So you have to be more gentle to female patients. Men are always stronger, but female are not. So endodontic treatment, non-surgical treatment, microsurgery will not remove phantom tooth pain from the patient who is deeply depressed or emotionally stressed. So you need to be careful. Let me show you a case. A patient was 37-year-old female. She had car accident 6 years ago. And she had traumatized tooth number 11. And she had sensitivity to heart. And tooth number 11 and tooth number 12. And also interdental papilla was sensitive to palpation. And the dentist performed palpectomy on tooth number 11 due to the persistent pain. But nothing changed. So he did non-surgical retreatment on the same tooth, tooth number 11. Nothing changed. Pain persisted. Then he had no choice. He extracted the tooth number 11. After the extraction, the patient had more pain. No change, nothing changed. Then she started feeling pain from tooth number 12, this tooth. And she had more pain. And the dentist performed palpectomy on tooth number 12 because of the persistent pain. More pain the patient had after the palpectomy. And the pain persisted for more than 5 years. I asked her. She was, of course, referred to me. When I saw her, I asked her, when did the pain start? Then she said, 5 years ago. Oh my God, 5 years ago. It's a chronic pain. So I don't think I can remove the pain by providing the dental treatment. So what would you do if you are in my position? When the patient arrived with these conditions, what would you do? Who wants to do the endodontic treatment? Actually, the original dentist asked me to do retreatment on tooth number 12, this tooth. Maybe something wrong. I took CBCT, and look, there was no periapical radiolucency, nothing wrong, right? So who wants to do the retreatment on this tooth number 12? Who wants to do the endodontic treatment? Nobody? Okay, who wants to extract the tooth? Nobody? Okay, what would you do? Go home? Pardon me? I cannot hear you. What? Drinking wine. No alcohol. Have more sweets. So actually, I told her to eat more sweets. Take more time in dinner time compared to breakfast and lunch. And she did. And immediately, she felt, not immediately, 1 week after what I told her to do, she felt so happy and she didn't feel any pain from the tooth. So I'm sure she had phantom tooth pain because of the accident. And she had chronic pain. And then the dentist didn't know the psychogenic pain. So that's why the dentist doing root canal treatment and extraction. It's a good thing he didn't extract this tooth. Unfortunately, he extracted tooth number 11. So this is phantom tooth pain again. Another case. The patient was actually, this was a male, not female. Patient was a male. Sometimes I have male patient with psychogenic pain. His complaint was remove pain from tooth number 32, this one. And he had pain whenever he had something cold. When he drank something cold, he had pain from this tooth. And when I did percussion test on this tooth, he jumped out of the chair. When I blew air against this tooth, he jumped out of the chair. And when I did electric pulse test, there was no response from this tooth. So what do you think? But I took a radiograph. I saw a small apical radiolucency, but this tooth was sensitive to blowing air and percussion pain. What is this? What is this? So who wants to do the root canal treatment? Nobody? Yes, you can do the root canal treatment because you see periapical radiolucency, but root canal treatment will not remove the pain from this patient. How do you remove this pain? How do you remove the pain from from drinking something cold? How do you do that? Why the patient is having pain when patient was drinking something cold? Why? Why? Come on, you know the reason. Psychogenic pain, phantom tooth pain, right? He remembered the experience, the pain when he had big pain, when he had something cold. He remembered that pain, and he was again depressed. He got divorced 2 months before he came to me. And he had an affair with another woman. And his wife was so upset, she actually kicked him, and he was injured. And so she was experiencing, the bad time with a patient. That's what he told me. Because you need to go private. You have to understand why he was having psychogenic pain. So I told him to, spend more time eating and take more sweets, vegetables, take more time, dinner time. Then after that, he became asymptomatic. Sometimes it doesn't work. In that case, I have no choice but to send the patient to psychologist or shrink, okay? Because he or she needs to take medicine, antidepressant or something. But we have, as I told you, descending inhibitory system. So we don't need medicine to get better. But, if you are desperate, if you are in deep depression, you need sometimes medicine to get better. So to make a long story short, when the tissues are damaged, pain signals goes to A delta fibers, and if you perform endodontic treatment, and if you see the healing, the pain is completely gone. But when the pain goes to C fibers, limbic system, and if you have, PTSD, then you suddenly remember something bad in your painful memories. Even if you do endodontic treatment, the pain will stay because the pain will become chronic. The only way to remove the pain, psychogenic pain, from the patient is to ask your patient to spend more time eating, drinking, talking, and more sweets. Then pain may be gone. But you have to change, you have to ask your patient to change his or her life. If they go back to the normal life, the pain will come back. If the pain goes to C fibers, hypothalamus, then you will start having more epinephrine. If you have lots of epinephrine, you have blood vessel shrinking, and your blood circulation will be slowed down. Then you have necrosis of muscles. In that case, you have lots of bradykinin. Then you need to prescribe NSAID together with acetaminophen. Then pain may be gone. So you have to either provide endodontic treatment or prescribe NSAID or tell the patient to spend more time eating, drinking, and talking. Or you have to do all. Endodontic treatment together with prescribing NSAID and telling the patient to spend more time eating and drinking and talking. Sometimes you need all. Sometimes one, sometimes two, sometimes everything. But you have to understand this mechanism of having the pain. Otherwise, you will not reach the goal. So now, changing the topic to the next topic. So what is the target for endodontic retreatment to remove infection from? So this is a very famous study done by Ray and Trop in 1995. So if you do a good endo treatment, but if you place poor restoration, your success in endodontic treatment will be 44%, very low, below 50%. However, even if you do poor endo treatment, but placed a good coronal restoration, your success rate in endodontic treatment will be almost 70%. So our endo success depends mainly on the coronal restorations. Because bacteria always come from the coronal restoration, the gap between the tooth and the coronal restoration. The bacteria will not be born inside the root canal. They all come from the oral environment. So again, Dominic is gone. He examined 39 obturated roots that had been exposed to the oral environment for more than 3 years. But he did histological study, but he found bacteria only in the coronal 1/3. No bacteria in the middle 1/3, no bacteria in the coronal 1/3. He found bacteria only in the coronal 1/3. Even though the tooth was open to the oral environment for more than 3 years, bacteria didn't get into the apical 1/3. Because you have more dentinotuberous in the coronal 1/3 as compared to the dentinotuberous in the apical 1/3. This is the reason. If you look at the apical 1/3, the dentinotuberous were degraded, sometimes calcified. No dentinotuberous. The more apical you go, the less dentinotuberous you see. But if you go coronal, you see more dentinotuberous. So this is one of the cases I did 20 years ago. So here, this is pre-op. I retreated this tooth because of the small lesion here. However, I placed the composite, and you see the gap. So because of the gap between the composite and the tooth, you see the patient developed periapical radiolucency after my retreatment. So I stained the gap with caries detector dye. You see the defect between the coronal the composite and the root, the crown. So I removed the infected dentin. Then in addition to that, I did root end surgery. So it's very important to close the gap between the composite and the tooth. Another case, it was done 1996, long time ago, almost 30 years ago. I was busy. I saw maybe 50 patients a day. I was very young, and I saw 50 patients a day. Too many to see. So I forgot to place root fillings in the canal. This is immediate post-op. I didn't take a radiograph. I was too busy to take a radiograph every case. I placed the metal post, and I took a radiograph. And I was surprised to see there was no root fillings in the tooth. But what was done was done. So I decided to follow the case. And this is a 2-year post-op. I think it's getting better. And this is 16 years post-op. Actually, there's no more periapical radiolucency here. And of course, the patient was completely asymptomatic. No more pain, regardless of the absence of root fillings. But I used a microscope already. And I isolated the tooth with a rubber dam. So I did my best to remove the bacteria from the root. However, this is 24-year post-op. The patient was stressed. She started bruxism. She started clenching, grinding. Then the root was exposed. Once the root was exposed, she had bacteria, more bacteria coming into the root through the dentinotuberous. Then I had problem. You see the lesion getting bigger. You see the patient developed a lesion. Look at the root completely exposed 20 years after my retreatment. So now I had no choice. But this is a good reason to retreat the tooth this time. So I filled the root with MTA. And this is one year post-op showing nice periapical healing. This is also CBCT. You see nice periapical healing. So it's important to close the root. Make sure there's no gap between the coronal restoration and the tooth. When the root is exposed, be careful. If you fill the root with Garrapatia and the Sera, Garrapatia does not bond to dentin, so you will have bacteria ingress into the root. So, is there any problem in the apical 1/3? Yes. We still have bacteria in the apical 1/3, but not in the apical dentin. No bacteria in the apical dentin, but you do have bacteria in the root canal spaces, small spaces, including an isthmus or apical ramifications. So if you don't remove bacteria from these small anatomical spaces, there's no healing. So you need to locate these small spaces with a CBCT. That is why I take CBCT every single case. Actually, the area in the apical 1/3 of the canal is 3 times larger than that in the coronal 1/3. So you have more spaces in the apical 1/3 compared to the coronal 1/3 because of the isthmus, because of the oval root canal shape and the lateral canal. You have more spaces. You need to spend more time cleaning the apical 1/3 compared to the coronal 1/3. And don't use Garrapatia fillings because it's not good to use Garrapatia fillings. Because a study from Osaka University showed Garrapatia, they located biofilms on Garrapatia in the Sera. And this is another study that came after the initial study done by Professor Ebisu. And they also located biofilms on Garrapatia in the Sera. So Garrapatia can be easily contaminated with bacteria, biofilms. Why in retreatment do you use Garrapatia in the Sera? You know biofilm can form on Garrapatia and the Sera. Don't use a material that allows bacteria to form biofilms. So you see biofilms on Garrapatia fillings. And this study shows the more gutta-percha used, the more, actually, the lower the success. So don't use gutta-percha. Use more sealer or calcium silicate-based cement. It's not good. Use gutta-percha fillings. So do you think single cone technique is better than gutta-percha fillings? Actually, there is no significant difference. So these studies shows the differences between single cone and continuous wave of condensation technique. In conclusion, there was no significant difference in the outcomes as long as gutta-perchas are used as a root filling material. So if you use gutta-percha, there's no significant difference in the outcomes. Because gutta-percha does not bond to dentin, the gutta-percha does not bond to sealer, nothing. So it will invite more bacteria into the root canal as long as you use it. So look at this study. Look at this case. The root fillings look nice on the CBCT. It's not overfilled, it's not underfilled. They look perfect, but you still see a lesion, periapical lesion. So I decided to remove the gutta-percha fillings and replace them with MTA. This is immediate post-op. I replaced the old gutta-percha fillings with MTA. And this is a 3 months post-op already showing nice periapical healing compared to this. I did nothing else. I just replaced the gutta-percha filling with MTA. That's all I did. Nothing else. Nair showed in 83% of cases, bacteria located in the last apical 2 millimeters of non-treated teeth with apical periodontitis. So whenever you see preoperative lesion, you have higher chances of bacteria living in the apical 2 millimeters, here and here. So if you don't remove the bacteria from this area, there's no healing. And Rikuchi located the same bacteria found inside the root canal with the bacteria outside the root canal. So if you do nothing about bacteria inside the root canal, bacteria will go out and develop on the root surface. So as soon as you see preoperative lesion, you have to start retreating the tooth. And also, if you look at the incidence of external apical root resorption associated with apical periodontitis, you see on average 80% of the tooth with apical periodontitis had external apical root resorption. 80%. Whenever you see preoperative radiolucency, 80% on average had external root resorption. It's a big number. So whenever you have preoperative radiolucency, you could have external root resorption like this. In this kind of case, there's only one material that you can use. That is MTA. Gutta-percha will never work in this situation. So prevention of coronal leakage is the most important. If you want to continue using gutta-percha in the sealer, that's fine. But prevention will be the most important to prevent bacteria from coming into the root. How do you do that? I always start with a coronal restoration. I use prime and bond reversal from Dentsply, Sirona, because the bonding, this system, work in a wet condition. You see, active moisture control. Too wet or too dry, no problem. So this bonding system works in a wet condition. the oral environment is always in a wet condition. You see saliva, you see something, fluid coming into the tooth, but the bonding strength will not be affected by the moisture. So that's why I want to use this bonding system. This is very good. I also use SDR. This is also a Dentsply product. Why I use this product? Because look at the shrinkage stress. This product shows lowest shrinkage stress. Okay? So, the drawback of using composite is polymerization shrinkage. But if you use this product has very low shrinkage stress. So that's why I want to use this product. And I want to use composite first, because if I start endodontic treatment, I must use sodium hypochlorite. If you use sodium hypochlorite, the bonding strength will be compromised because of sodium hypochlorite. But it's never too late to regain the bonding strength. If you use EDTA, if you use sodium hypochlorite, the bonding strength will be back to normal. So whenever you use sodium hypochlorite, make sure you use EDTA before you apply the bonding system. So this is what I do. So whenever I see caries, I use caries detector dye to remove infected dentin. So I removed infected dentin, I build up the wall, the missing wall, with composite. I use the prime and bond universal. I use SDR. On top of SDR, I use normal composite. So for example, I never use removable composite restorations. I never use removable temporary coronal restorations because it allows leakage, coronal leakage. So what I do in normal situation is I use prime and, after removing caries, I use prime and bonding universal. I place SDR on the root, then I will place normal composite to make it look like a normal tooth. And of course, there's no gap between the composite restoration and the root. So this prevents the coronal leakage. So this, for example, this, you see the lesion, and this is the tooth I'm going to treat. I remove the coronal restoration, and I placed composite coronal restoration, bonded to the tooth. So this way, you can prevent the bacteria ingress into the canal. So if you do that, you can have healing. Another case, I remove the coronal restoration, I remove the post, I placed composite, bonded to the tooth, and this is MTA. And this is 3 months post-op. You see nice periapical healing compared to the pre-op radiolucency.